Good morning, good afternoon, everyone, and welcome to a session at the Community Connect at the Union. To begin, I just want to note that this particular session, there is interpretation available, so you can listen in either English or in Russian. Should you wish to pick or select your language at the bottom of the screen, you'll be able to see next to the chat and the Q&A an option for interpretation, and you can select either English or Russian there. So I would encourage you all to just take a moment now to select your language of preference. So now to commence, and I want to thank the fantastic panelists that we have here today, and thank you for inviting me to be part of your session. This session is going to be looking at community rights and gender, and some assessments that have been done in the Eastern European and Central Asian region. For those, many of you may be aware that some broader work has been done in this particular area, in many ways impacted by the United Nations high-level meeting on TB and the various targets and commitments there, which talk to different themes, such as removing legal and social barriers to access, eliminating stigma and discrimination, the meaningful engagement of people affected by TB and key and vulnerable populations, among other areas. And these assessments look very much at TB responses at national and regional level to understand how they are dealing with these particular commitments. So without further ado, I want to hand over to our first speaker, Nonna, oh no, sorry, I got that wrong, to Liliana, to provide a little bit of context for us about the rationale of these CRG assessments in the EECA region, the TB REP project, and to set up the discussions for today. So over to you, Liliana.
Just 1 second. Hello, everyone. Thank you for being with us today. It's a topic of interest for us, but I hope it is for you also, those who joined. The European region, as you know, is the region with the highest rate of drug-resistant tuberculosis in the world. And it's also the only region in the world where TB, HIV co-infection and mortality rates are still growing. TB REP include 11 countries in Eastern Europe and Central Asia that make substantial contribution to this burden and are at the top list of countries with TB mortality. TB REP is a multi-country, multi-partner project that brings together a various array of partners at both regional and country level. It's a global fund project that runs between years 2019, 2021, and is the second one project continuing the first goal to bring on the table the people-centered model of care. The project aims at removing barriers, as you can see, either at community or at health system level through the involvement of TB communities and civil societies, as well as the development of integrated people-centered approaches focused on meeting the needs of key populations. Stigma and discrimination, human rights and gender, as we all know, are key cross-cutting bottlenecks towards TB people-centered model of care and the main factors that affect the cascade of care and the poor TB outcomes we have in the region. So the challenge to find the people with TB remains important in most of our countries, as we have more than 20% of people that are missed for TB programs. The CRG assessments, which is a topic of our discussion today, is basically aimed in our region at collecting evidence on barriers to find people with tuberculosis who are missed by the national programs and who delay care, with a final goal to improve both the case finding and the cascade of care. We have here on the right part of the screen the countries from TB REP region that went through the CRG assessment starting 2016 to 2020. Armenia is the last one that just embarked this fall into the exercise. We expect that at country level, the findings that countries have will use to address barriers to timely and quality care and revise case finding strategies and case management strategies in countries to bring so that these are right and gender-based and responsive to the needs of key affected populations. At regional level, it is expected that country findings and the regional overview that will be introduced to you soon will inform WHO case finding strategies, and also will trigger some focused technical assistance from WHO to country so that to help them to adjust the strategies so that they are tailored to the needs of most affected populations that remained uncovered, unfortunately, today. Over. Thank you, James.
Thank you so much, Liliana. I might ask you to stop sharing your screen now as we move on to Nona's presentation. But just before we start with Nona, I just wanted to acknowledge the work under the TB Rep project. There has now been around 16 or 17 countries that have completed these CIG assessments, and most of which were supported under the Global Fund Strategic Initiative on finding the missing people with TB. And there's been a significant increase of engagement in the EECA region thanks to the support from the TB Rep project. So just wanted to acknowledge the partners there. Now I want to move on to the second speaker, to Nona, who's going to talk us through a little bit about some of the results that came out of these assessments in the region, and to, I guess, talk us through the process and why these results are significant in the context of national and regional TB responses. So over to you, Nona.
Hi, so my name is Nona. I'm a freelance consultant working in tuberculosis and public health. I would like to acknowledge the team who have contributed to this work. Some of them are in this meeting. They are Kristina Zharaeva from Kazakhstan, Samantha Sokolovsky from Germany, and Peter Mok based in Malaysia. I would also like to acknowledge the continuous support of the TB Rep team and PAS Center in Moldova. I hope that the information I'm about to present is going to be equally useful to the participants from the Eastern Europe, Central Asia, but also to the participants from other parts of the world who are probably planning to embark on similar assessments. The title of this presentation is Breaking the Silence. As people with tuberculosis, community or family members or service providers, we are all already aware of some of the barriers such as informal payments for services, loss of income during treatment, or gender-based violence. Sometimes we feel problems are unsurmountable or too sensitive to discuss. However, without naming them first, it is difficult to start finding the solutions. And that is exactly the purpose of this presentation, to introduce and discuss some of the common barriers and ways to overcome them. A note on what was analyzed and how. From 2016 to 2020, several CRG assessments and reviews, including the Global Fund Breaking Down Barriers assessments, were conducted in the region, including the countries you can see on the left. We collected and analyzed the available reports, and also where applicable, the national TB strategies and the Global Fund funding requests, to see if and what CRG recommendations were taken on board. I'd like to note that the assessments supported by TB Rep especially emphasize the importance of the community and multi-stakeholder engagement. And Mariam Djibouti from Georgia, who will speak next, is going to tell about this in her presentation. The most common barriers that I would like to discuss in this presentation are extreme discrimination of some key populations, consequences of tuberculosis for women, stigmatization by healthcare workers, and the persistent lack of people-centered approach. The complete report has more information about other barriers and also the details of the proposed country-level solutions and recommendations. The assessments show that people who use drugs and people with a history of imprisonment, especially women from these key populations, appear to be the most vulnerable and stigmatized. People who use drugs have difficulties accessing services because of their criminalization, and people with a history of imprisonment encounter barriers when they do not have national IDs or a passport, which happens frequently following imprisonment when they do not have domicile registration, a document needed often to get access to primary health care, or some of them are or end up homeless. For these key populations, an encounter with law enforcement may result in interrupting whatever treatment they're on, which is direct violation of their rights. To repeat, it is especially women from these key populations who experience higher levels of stigma and discrimination when they meet with healthcare workers or the police. One of the solutions is improving service integration, and that includes co-locating opioid substitution treatment, HIV, and TB services in the lowest threshold setting. And improving service comprehensiveness can be through the inclusion of peer educators and the work of multidisciplinary teams. For instance, one of the countries proposed multidisciplinary teams to visit prisoners with TB who prepare for release, to include legal experts who could signpost patients to relevant services. Then we have training for police and prison staff. And a couple of examples are, where possible, including TB relevant information into already ongoing activities of the HIV programs, such as training for the police and the prison staff on tolerance and human rights. And introducing human rights, including the right to medical care, into the curriculum of pre-service police training institutions. There are many ways to improve rights awareness of key populations, starting with informing them what services are for free and what are the rights and responsibilities of people with TB. In all the countries, the proportion of notified cases is larger in men than in women. Clearly, TB in men needs a gender-responsive approach, and I will get back to it when I talk about people-centered care. Across the board, women show better adherence and better treatment results, but it is women who have to overcome larger barriers, such as scarce finances, lack of family support, and gender-based violence. In all countries, women carry the burden of unpaid household work and limited childcare options. Their lack of decision-making over finances leads to deprioritizing women's health needs, delaying health diagnosis, delaying TB diagnosis, and sometimes delaying TB treatment. Self-stigma is higher in women. In several countries, women spoke of physical, psychological, and economic violence in relation to TB and violations of their reproductive rights. Gender-based violence in TB is rooted in stereotypes, power inequalities, lack of information, and TB myths. Women face such catastrophic consequences of TB as self-stigma, divorce, separation from children, discontinued pregnancies, and multiple issues in case of women-headed households. Some of the recommendations are, first, starting or continuing to disaggregate data. Disaggregating all indicators into men, women, and others, including but not limited to drug-resistant TB, TB HIV, and such treatment outcomes as mortality or loss to follow-up. This will help monitor programs and design appropriate gender-responsive interventions. In case of TB and pregnancy and breastfeeding, we need to provide counseling or family planning, advice to pregnant women on the risks related to treatment, and help breastfeeding women with TB understand what they should and shouldn't do. We need to take a family approach to supporting people with TB, which means addressing myths, identifying potential barriers to adherence, and preventing violence. Further, in addressing gender-based violence, we can think of training treatment supporters and multidisciplinary teams in recognizing and supporting someone who is living with an abusive partner or family member, linking GBV survivors to medical and legal services, and educating the management and employees of the shelters about TB and how to support GBV survivors with tuberculosis. Stigma is often linked to a lack of or breaches of confidentiality and discrimination by healthcare workers. At the same time, many national strategies and funding requests to the Global Fund identify healthcare workers as one of the high-risk TB populations. There is that increased risk of TB infection, non-responsive compensation schemes, and a lack of labor and legal protection. In high stigma working environments, healthcare workers who become ill with TB prefer to self-treat or otherwise bypass the system because of the negative attitudes from their supervisors and colleagues. So addressing stigma and discrimination by healthcare workers needs to start with improving their working conditions, including infection control, developing and implementing strict and clear protocols regarding confidentiality, and where necessary, intervening to change in-house behavior from bullying and stigmatizing to respecting and supporting healthcare workers who have TB. This could be coupled with training healthcare workers on key populations, gender tolerance and human rights and patients' rights, and including these topics into the curriculum of pre-service, postgraduate, and continuous education. The last barrier and solutions that I would like to discuss is the lack of patient-centered approach. Even within any key population, the conditions of people with TB vary and require a corresponding set of interventions. Across the board, the lack of childcare provisions for women with TB affect their ability to attend a facility-based, directly observed treatment. Especially during the times of COVID-19, there are difficulties receiving DOT. In some rural and remote areas, DOT has never been available at all. So people-centered care interventions, taking into account the individual circumstances, are a way forward. And this includes differentiated patient or case management, how it is known in HIV. A case manager assigned to TB patient does not necessarily have to be a medical worker. It can be a trained NGO member. It is important that case managers have a client-oriented mindset to be able to help the most vulnerable navigate the health and social security systems. Case manager evaluates each patient before treatment to establish their situation, needs of financial, social, psychological, and mental health support, possible gender-related or other barriers to adherence, and the best modality of providing treatment. Finally, identifying patients to whom regular support will not be sufficient and engaging them in enhanced support by multidisciplinary teams. In terms of confidentiality and contact investigation, it is important that the case manager builds rapport with the patient, explaining the importance of contact investigation and underlining the confidentiality of the patient's diagnosis and motivating the people with TB to provide the relevant contacts. There definitely needs to be more than one treatment delivery option, including but not limited to clinic-based DOT, community-based DOT, multi-week dispensing, and video-observed treatment. The choice of treatment provider needs to be discussed at the intake with each new patient, and it can be revised. And the last possible intervention is counseling and addressing self-stigma. This means making psychological care and mental health support available for TB patients at all stages of diagnosis and treatment, including online counseling for people whose ability to come to the healthcare provider is limited, and engaging NGOs to train and deploy peer educators and treatment supporters. So this is the last slide of my presentation. It was my pleasure to present to you the regional overview. There will be a public launch and discussion of this document in November. For more information and a copy, please contact Past Center at the addresses provided on this slide. And please keep in mind their Facebook for the exact dates of the November launch and discussion. Thank you very much.
Thank you so much, Nonna, for that wonderful presentation and the introduction to lots of the findings and the recommendations that came out of the study. I think I just wanted to just take a moment, if I can, to just talk about talk about 2 quick points. And one of them is very much looking at the context of this. And it's when we're talking about addressing barriers and finding the missing people affected by TB, one of the first steps is we need to be able to identify the barriers first and build an evidence base around that. And in the context of TB, in many countries, this sort of research and understanding is relatively new. So I think that just to frame what you just said a little bit and why that is a significant contribution and why it can be so valuable to national TB programs in your region and beyond. And the second thing I just wanted to talk about, and hopefully we can come back to it more in the discussion, is the points you were raising on gender. Because obviously, I think there's a natural instinct to look at prevalence of TB among men, and that being the start and end of a TB discussion on gender. And in the chat, I've just added an investment package around gender and TB. And I think all the points that you raised is very much relevant to this need to consider people on TB treatment as more than just patients, as to being people who are complex, who bring a whole society and a range of norms with them, and those challenges and barriers that those individuals face across their lives are relevant to TB. And so for the TB programs to be effective, we need to take that into account. So thank you so much for that presentation, and I'm sure we can discuss more in the discussion session at the end. But if I can now, I just wanted to also move on to Mariam. And I think this is a really interesting opportunity to talk more of some of the points that Nonna originally raised, looking at the idea of TB, key populations. And I know that this is going to be focused particularly in the context of Georgia. So over to you, Mariam, to talk us through that. Thank you.
Good day, everyone. I hope you see the presentation previewed. So first of all, my name is Mariam Djibouti, and I represent the organization New Vector, which is based in Georgia. So my presentation will consist of 4 stages. Those will cover issues of CRG being led by key populations, how core group members were chosen and engaged in the process, choosing and training peer data collectors, and how multi-stakeholders consultations were held. First of all, it needs to be mentioned once again that my organization, New Vector, is a drug user community organization delivering harm reduction services under both national programs and international grants. So our experience in the field and the trust from the beneficiaries helped us to connect stakeholders on national and international level to the community key populations. As a result, this ensures the involvement of the community sector in the decision-making process. So let's move on to the core group members. They were representatives from community organizations that had experience with our key populations, also the governmental sector, and specifically this for us was Center for Tuberculosis and Lung Disease Control, and the research organizations which had some experience assessing similar subjects. That was interesting to us also. So those persons helped us in the process of choosing the multi-stakeholders, providing sources for the desk research, engaging in the process of questionnaire contextualization, considering that the assessment was going in Georgia, reflecting on the desk research drafts and helping us with the beneficiary recruitment process. Also reflecting on the multi-stakeholder meetings, getting feedback on research drafts, contributing in the process of creating informational material, and needs to be said that our communication was mostly held online, and it was very flexible, to say so. After the desk research was kind of done and we had some information on our hand, our organization started preparing for the multi-stakeholder meeting. And the purpose of the meeting was presenting the desk review on key information and aspects covering community rights, gender, and background regarding the TB high-risk groups in Georgia. And it was also the overview of the tools and the structure to be used in the assessment, prioritizing between TB high-risk groups to be covered by the assessment. So within the during this process, our multi-stakeholders helped us to choose our key populations, which were 3 in the end: people who inject drugs, internally displaced people, and former prisoners. So after we knew who our key populations were, we started recruiting the peer interviewers, total of 4 interviewers with the experience of working with the risk group representatives or community groups who had the background of social work, psychology, or peer education were recruited. And the interviewers received training for the guidelines, contextualization of issues, and confidentiality issues, of course. So after this, when we already had the information gathered after the field work was done, and we had our main results on hand, the second multi-stakeholder meeting was held. So the purpose of the meeting was to present, validate, and prioritize the barriers related to community rights, gender, and stigma, to outline the recommendations to remove prioritized barriers and to draft actions for inclusion into TB strategy. And this process was led by considering the TB journey stages and regrouping the barriers, recommendations, and actions into each stage, which are recognizing symptoms, seeking care, getting accurate diagnosis, beginning treatment, getting treatment adherence support, completing treatment, and getting post-treatment follow-up services. So this process allowed us to formulate concrete actions, which were assigning a memorandum between organizations working in the field of tuberculosis, including the TB Center, and this stage has already been done in our country by us and between 4 organizations. So second one was creating informative photo and video material on the identification, diagnosis, and treatment aspects. Also conducting training with the TB on the TB awareness, NGOs and staff working with them to raise awareness about TB, and conducting the round table, which is also the advocacy for one window principle services and strengthening the outpatient treatment. So that is all from our experience for me.
Thank you so much, Mariam, for that presentation. I just wanted to just make one point here, and it's that we talk a lot around meaningful community engagement in the context of TB, and it's becoming an ever increasing buzzword in the TB response. But understanding what that actually means is something that's quite different, I think, to where we are now. And I just want to acknowledge the work of New Vector here, because I think it's one of the few CRG TB assessments that's been led by a key population network. And so that's really wonderful. It's exactly the kind of change that we need to see, because that idea of meaningful community engagement is not just asking a certain group what they think, but it's sort of empowering them and supporting them to lead the process and really lead the idea of the agenda setting, priority setting, and governance. So amazing work out of Georgia. So well done, and thank you so much for sharing with us. Moving from Georgia to Kazakhstan, Oksana, who I believe you're going to present in Russian. So I think this will be, we can test the translation approach, and to talk a little bit around some of the opportunities and challenges that came out through the study in Kazakhstan. So over to you, Oksana.
Здравствуйте, уважаемые коллеги. Разрешите вас поприветствовать от имени неправительственного сектора, гражданского общества, которое работает в сфере туберкулеза и ВИЧ Казахстана. Спасибо большое за возможность показать результаты, краткие результаты нашей оценки. Если можно, следующий слайд. В Казахстане у нас прошла оценка в 2019 году. Результаты были готовы уже к марту 2020. К сожалению, из-за коронавируса где-то эпидемия нам, ну, как говорится, долго мы согласовывали вот именно все данные с отчета с NTP-программы. Но у нас получились очень интересные результаты. Мы совместно с NTP-программой смогли по результатам анализа создать план действий. Рекомендаций, конечно, очень много. И вот уже вот у нас небольшой проект до конца года, когда мы стараемся воплотить в жизнь какие-то, ну вот, несколько рекомендаций. Самое основное то, что получилось нам сделать, что мы в результате этой оценки получилось пока вытащить вот гендерные проблемы. До этого как-то этот вопрос никогда не поднимался в разрезе туберкулеза, ну вот на мой взгляд. И здесь много было вот проблемных моментов, когда мы вытащили именно моменты касаемо там женщин, прав гендера и в разрезе получается, нормативно-правовых актов, и уже на пути излечения, диагностики. И вот, ну, наша задача, конечно, вот уже устранить эти гендерные, связанные с правами человека, барьеры. Мы акцентрировались сейчас на 3 задачах. И можно следующий слайд. Это вот первое, это интеграция идентифицированных гендерных подходов. И сейчас мы пытаемся сделать алгоритм ведения кейс-менеджмента с учетом вот гендерных аспектов. К сожалению, ну, в Казахстане вот вопросы гендера, они, ну, чувствительны, но не так сильно, ну, не знаю, на мой взгляд, это все говорится. Ну, и вот в результате оценки у нас появились такие данные, что женщины больше подвержены, больше уязвимы. И на это нужно обратить внимание и сделать так, чтобы те же программы по туберкулезу, ну, как-то вовлекались, участвовали в этом и изменяли те и нормативно-правовые акты, и те практики, которые мешают, ну, до конца пройти лечение. Вот. По гендеру у нас было несколько таких рекомендаций, которые касались изменения вот именно нормативно-правовых актов. Что радует, то, что во время принятия отчета, во время, ну, проведения вот, ну, круглых столов, встреч вот именно с лицами, принимающими решения, некоторые даже барьеры мы смогли уже изменить. У нас как раз в это время менялся новый, вошел кодекс о здравоохранении, и некоторые моменты мы исключили. Вот, и, кстати, вот благодаря этой оценке, то, что публично, открыто были сказаны вот те проблемы, те барьеры в нормативно-правовых актах, которые мешали, допустим, женщинам с туберкулезом, но которые у нее не активный туберкулез, попасть в те же кризисные центры, которые рекомендованы для женщин, которые столкнулись с жестоким обращением, с бытовым насилием. Это было барьером. И этот вопрос поднимается на разных уровнях, ну и уже вот есть все предпосылки, что это изменится. Также в результате оценки вышли такие барьеры, то, что женщину сложно во время лечения отправить детей в дом малютки. И это сложный процесс, это долгий процесс. И, естественно, женщина очень переживает и за свое здоровье, за здоровье своих детей. И также эти вопросы поднимаются. И, ну, сейчас вместе совместно с противотуберкулезной программой, совместно с нашими партнерами, ну, пытаемся вот эти все вопросы поднять и изменить. Также вопрос по репродуктивно-сексуальному здоровью, то, что мало информации получают, ну, и как женщины, так и мужчины в тех же поликлиниках, и необходимо уже вот усилить эту работу, чтобы и в фтизиатрии, и чтобы первично-медицинская сеть вопросы эти поднимала. Сразу при скрининге даже на туберкулез, ну, какие-то вопросы включить, чтобы они включали по гендерным особенностям и по насилию, чтобы уже врач уже понимал, что если женщина уже, ну, какие-то вот вопросы, чтобы были. Следующий слайд. А также вопросы по стигме. Ну, здесь большой пласт работы. Все, наверное, знают, что как сама стигма, как ну, стигма дискриминация, как и в медицинских учреждениях она присутствует, ну, что скрывать. И когда мы приоритизировали ключевые группы, у нас мы совместно решили, что это будут люди, живущие с ВИЧ, и внутренние мигранты. Внутренние мигранты, которые перемещаются в стране из города в город. И вот много вопросов вышло вот именно с этого момента. И вот стигма как раз присутствовала по отношению к этим людям. То, что ну, двойная стигма, если человек, живущий с ВИЧ, если туберкулез, это все присутствовало. Здесь поэтому необходимо делать большие кампании, необходимо вовлекать сообщества, противотуберкулезные диспансеры. Ну и вот этот вопрос, не знаю, ежедневно, постоянно поднимать. И вот, к счастью, у нас сейчас очень большая акция, социальный флешмоб идет в социальных сетях, где мы сделали хэштегом «Болеть не стыдно». И прям радует то, что очень много людей отзываются по этому поводу, буквально минутный там видеоролик, вот именно мнение, почему это не стыдно, почему нужно лечиться, то, что стигма здесь неприемлема. Вот, это очень радует то, что откликается как и сообщество, как и ну, медицинские работники. Следующий слайд. По правам, ну, опять же, амбулаторное лечение у нас есть, все бесплатно, но не всегда учитывается пациент-ориентированный подход, не всегда, к сожалению, информируют пациента, что он может не ложиться в больницу, он может, допустим, с видеоконтролируемым лечением. Не всегда информация это дается, и очень много вот таких вопросов мы поднимали. Опять же, необходимо усилить работу социальных работников. К сожалению, мы уже давно проводили такой анализ, что социальная поддержка, ну, она очень играет большую роль, и необходимо, чтобы она была и доступна и для всех ключевых групп. Следующий слайд. Ну и главный месседж, наверное, моей презентации, то, что необходимо, чтобы ну, все вот наши рекомендации, чтобы всем нам вместе вот все эти вопросы решить, здесь нужно очень четкое взаимодействие и включая и сообщество, и противотуберкулезный диспансер, и ну, в общем, если только вместе мы сможем что-то изменить, только вместе мы сможем изменить подход, и вот именно в отношении мер по туберкулезу, чтобы сделать их ну, справедливыми, основанными на правах человека и ориентированные, ориентированные на людей. Вот. И это вот самый главный слайд, то, что мы поняли, что мы сами не сможем это делать, только совместными усилиями, совместными действиями мы сможем изменить практики в отношении туберкулеза и сделать их доступными, лучше и основанными на правах человека. Спасибо.
Thank you so much, Oksana, and to our wonderful interpreter as well. I think that was really good to hear. It was really, I think, thanks also for bringing up the issue of stigma in the context of healthcare settings. I think that is something that we are just starting to understand more, and there is a recently developed TB stigma assessment that can be used to set a baseline for the experience of stigma in the community and in healthcare settings, which might be something that would be useful in Kazakhstan and other countries on the call. We have a few minutes left, and I want to open for questions. I note that there's a question from Anna in the looking at the context of LGBTI communities, and I wonder if there was anything that came up over the course of the assessments in Georgia, in Kazakhstan, or for Nona in the other countries as well, where this was something that came up, and any responses or reflections you have on that. And a second question I'd like to just pose to everyone, and so you can consider both, is what do you want to do now? What happens next? You have these findings and these recommendations. Do you have any clear steps to maybe institute these at the country level to, I know, and to get these to measure and evaluate the change and that sort of thing? So I think I'll open to, if any of the speakers want to jump in to respond to either of those questions, please go ahead. Nona, I see you raised your hand. Go ahead.
Just very quickly, Anna, I'm really sorry about what happened to your friend in Kyrgyzstan, and I feel that with you. Both countries did special efforts to reach out to LGBTQI communities. However, of course, the information is very limited. In Georgia, there was at least one case uncovered of some human rights violations, and that was also discussed with the stakeholders. Regarding next steps, we did also look into the uptake of the recommendations in the Global Fund proposals and national strategies, and we can say that among the several countries that slowly but surely the CRG recommendations do find reflection in the strategies and in the budgets. But Oksana and Mariam are better placed than me to add on to that. Thank you.
Oksana, did you want to comment? Or Mariam?
Да,
Mariam,
я могу немножечко прокомментировать. Ну, к сожалению, то, что группы, которые были выбраны, люди, живущие в СВИЧ, внутренние мигранты, ЛГБТ-сообщества не было. Но мы вопросы гендера в этом отношении поднимали. И сейчас, если говорить о тех действиях, которые мы хотим делать дальше, потому что мы понимаем, что проблемы есть, и просто мы еще вовнутрь этой группы не зашли, вот именно в разрезе туберкулеза. Ну вот как-то в Казахстане, вот не знаю, потому что у нас не на весь Казахстан, а всего 2 области было охвачено. Вот. Но самое главное, то, что, ну, я, наверное, хотела бы вот похвастаться, то, что дальнейшие действия, то, что у нас сейчас будет внедряться мобильное предложение ОНПАК. И я думаю, в дальнейшем мы вот эти все проблемы, если мы постараемся его распространить, там как раз есть возможность реагировать, мобильно реагировать на все вопросы стигмы, вопросы дискриминации, вопросы доступа к лечению. И я думаю, здесь в разрезе гендера однозначно мы будем стараться вовлекаться и реагировать, потому что, возможно, мы не все проблемные моменты знаем, но мы очень хотим это делать, и мы это будем делать. Вот. Пока вот одно у нас такое из решений.
Thank you very much for that answer as well. And just before we conclude, Mariam, I'm not sure if you have seen, but there's a question in the Q&A box relating to Georgia, and it talks about creating an epidemiological profile in the context of key populations and people affected by TB, and whether that was part of the assessment, and additionally, just sort of any challenges you experience in that context. I wonder if you want to comment on that just before we wrap up.
Yes, yeah, I will comment, of course, and I want to say that our assessment did not involve like the epidemiological profile, to say so, and just to make kind of the overview about the gaps and maybe the problems in the assessment process, I would say that mostly it was that in the process of the interviews, it was kind of visible that most of our respondents were very subjective, or maybe they spoke of the experience that was that has happened to them like very long ago, and they could not remember the facts correctly in details or something like that, and we had to really try our best to avoid any misinformation because of their emotions when talking on those subjects. Mainly, this was the problem, to stay as correct as possible.
Thank you so much for your reply on that. And I think as well, just to Kruger as well, to note that I think a lot of the epidemiological side around TB in key populations, there's an ongoing work here and are needed for an ongoing and follow-up work. In many ways, this assessment serves to prioritize. And then I think that some of the things that you're talking to would almost be that next step, having prioritized and identified those populations. So one of the ways in which to I guess, take forward and do that next step is around costed CRG action plans, which can be developing costed interventions that respond to the recommendations. And these sorts of plans have been developed in several countries. And that's something I think to consider for Georgia, for Kazakhstan, and for the other countries in the region that have done these assessments. And I think I just wanted, just before I close, because I know at the time, I wonder, Liliana or anyone, did you have any final comments that you wanted to make before we wrap?
Thank you, James. Dear all, you raised quite a lot of issues which really make sense to be discussed in more details. The session is short, but we will have a follow-up meeting in November, where we will discuss both regional overview, but also country cases. So we will have again New Vector and Kasoyuz with us, but not only. We will have a Tajikistan team with us, the Ukrainian and the Kyrgyzstan one, and I hope Armenia will get some desk review by that time to be with us and share their findings. The scope will be also not only to discuss how we deal with the issues at country level, but also take this forward and think about how this learning can be used at regional level, because most of the barriers that have been assessed in each and individual countries are common for more than one country, as you have seen from Nona presentation. So please be with us in November. Follow our webpage and you will find, but also the web pages of Kasoyuz and New Vector for the country level reports. Look for them, make your questions, and be with us in November to discuss in details and contribute to our common goals in the region, help the countries and help the region to improve case finding and to improve the cascade of care for people with tuberculosis and those most affected. Thank you.
Thank you so much, Liliana. From the side of Stop TB Partnership, congratulations again to Paz Center and all of the country partners involved in these CRG assessments. It's really wonderful to see this work progressing. I think we're all starting to acknowledge and understand that the promotion and protection of human rights involves identifying and removing these barriers. And this is important, not just because it's the right thing to do, although that is critical, but because it'll actually help us to strengthen our TB programs at the country level and ensure that everyone, no matter where they live or how they identify, can access the services that they need. So with that, I want to conclude. Thank you everybody for joining the session and the discussion. And as Liliana said, for everyone in the region, hopefully this is something that you can continue to engage in, particularly at the regional meeting that will take place in November. Thanks everyone and have a nice afternoon.
Mm-hmm.